Hey, Andrew Wolf here, and I'm going to talk about the physiology of the cardiac cycle. Now, here we have a couple of pictures. This is a picture of the the heart, and I just sort of scribbled out the right heart here because I really am going to be just focusing on the left heart. And you're just going to have to remember that the same processes are occurring simultaneously in the right heart. But it's easier if you just think about the one half of the heart at a time. Okay, so over on the left side of the screen here, we have a diagram of what is going on in the pressure. So this blue curve here is a pressure curve, and the volume, the red curve here, is a volume curve, and then the EKG. Okay, so I'm going to start out here, sort of in the middle. I'm going to start out right about here, and this is all occurring over time, so we have time down here. And then we also have what's called a phonocardiogram, which is the heart sounds. First S1, S2, S3. Okay, so again, I'm going to start here some in the middle, and this is sort of at the beginning of diastole. And we'll take a look, actually, I want to take a look first at what's going on with volume. And then, because pressure really sort of relates to what's going on with the volume. So pay attention to this red curve first. This is the volume curve, and we're starting out right here. And right now, the ventricles are just starting to relax, so it's the beginning of diastole, and they've just ejected most of their contents. So there's still about 50 cc's of blood in here. There is some blood remaining, because remember, nobody has an ejection fraction of 100%. A good healthy heart will have a ejection fraction of around 65 or so. So there's 50 mLs of blood already in the heart, and it's going to start to fill. Now, how's it filling? It's just filling passively, because blood is flowing through the atria, through the atria that are relaxed, and into the ventricles based on the pressure from the pulmonary vein. The pressure from the pulmonary vein is pretty minimal. It's going to be about 2 centimeters of water or less. It's going to be very low. So it's near zero, but it's enough to keep the blood flowing. So the ventricles are filling, and they fill up pretty substantially, but it starts to slow as they get filled. So you fill up between maybe 50 and 120 mLs just through this passive filling of blood flowing in through the pulmonary vein through the open mitral valve. Then we have our P wave, right? The next step is we have our P wave, and what does the P wave do? It causes the atria to contract. So we end up with atrial systole, and that kicks in this extra volume from 110 or 120 mLs up to the final 130. So atrial kick adds 10 to 15% of total volume. So most of this again is just passive filling. The atria just add a little bit. Okay, and you can see that the atria, this blue wave is the pressure wave in the left ventricle. So the atrial kick, by adding that extra little pressure and pushing the blood in, it raises the pressure of the ventricle just a little bit, maybe from 0 to, from like 2 centimeters of water to 7 or 12 centimeters of water. But it's enough to get the remainder of the blood into the ventricle. Then we have our QRS wave, and our QRS wave initiates ventricular depolarization. Now I'm going to switch back over to here because this has the nice labels. So this marks the QRS wave here marks the beginning of ventricular systole. So what happens with ventricular systole is the ventricles start to contract as they depolarize, and the pressure of the ventricles contracting close the mitral valve. So AV valve here stands for atrioventricular valve. Mitral valve is one of them. The one on the right side of the heart is the tricuspid valve. So the mitral valve closes. And actually, here, let me go back. All through diastole, the aortic valve has been closed. So now we are in a situation where called isovolumetric contraction. It's called isovolumetric because both of these, the ventricle is completely filled with blood. It's got its 130 mLs of blood in it. And both of these valves are closed, right? Now, why are they closed? Well, the mitral valve is closed because of back pressure pressing on it from the ventricle. That's what's holding it closed. And what's keeping it from blowing back into the atria is the chordae tendineae right there. It's a nice floppy valve. What's keeping the aortic valve closed? The diastolic pressure in the arterial system. So there is pressure in the aorta. What's normal diastolic pressure? Around 60 millimeters of mercury. So this valve cannot open until we overcome this pressure. So for the first 1/10 of a second or so, after the ventricles start to contract, nothing happens until we build up the pressure to open the aortic valve. So when does that happen? That happens somewhere around here when we overcome the pressure of diastolic blood pressure, because that is the pressure in the aorta. So then, as soon as we overcome that pressure, the aortic valve snaps open. The pressures continue to rise in the ventricle because the muscles continue to contract. So we have all this inward pressure. So the pressure continues to rise even as the aortic valve opens. And then as the ventricle empties out, it starts to go back down again. So you can see the pressure rises and starts to fall again as the volume in the ventricle goes down because of ejection of the blood. Okay, now when the pressure drops below diastolic blood pressure, below the pressure in the aorta, the aortic valve is going to close. And then this is the beginning of diastole. The ventricles continue to relax and relax and relax until we get the pressure down to 0, and then we start passive filling of diastole again. Okay, so let's talk about the heart sounds. We've got S1, S2, and S3. So what causes S1? Well, S1 is caused by the back pressure of blood, the sort of turbulence of blood that occurs after the mitral valve closes. So S1 occurs because of the mitral valve closing at the beginning of ventricular systole. Okay, now S2 occurs as the aortic valve closes, and that occurs at the beginning of diastole. Now S3 is a sound that occurs with sort of young healthy people or athletic people because of rapid filling of the ventricles. And the theory is that it actually, I think in nursing school we teach Kentucky, Kentucky, Kentucky as the sound for S3. But you can also remember it as sloshing in, sloshing in, sloshing in, because this kind of explains what's happening. The blood is sloshing rapidly in from passive filling into the ventricles, and it's that turbulence caused by that sort of sloshing in that causes it. So you'll recognize the sound because it sounds like sloshing in, and that also explains the physiology of the heart sound. Okay, so one other thing that I wanted to talk about that relates to the cardiac cycle is the determinant of cardiac output that is symbolized by CO. So cardiac output. Cardiac output equals stroke volume, or SV, times heart rate. Now, what is stroke volume? Stroke volume is going to be the amount of filling of the ventricle minus the amount of blood that is left behind in the ventricle, or the total volume of the ventricle times the ejection fraction. So let's talk about the ejection fraction for a minute. So the ejection fraction is the percentage of ventricular volume that is ejected into the aorta after. Now, normally it's around 60%. So we will always have about 40% remaining in the ventricle at diastole, even with someone healthy. So, 60-65%. So if you have a ventricle with a volume of 130 mLs, if you multiply this times 0.6, or 60%, then you will come up with the stroke volume. The stroke volume is the amount that is actually expelled into the aorta. Now, that gives you a value of well, 78 if you do it exactly, but around 80 mLs. So again, the stroke volume represents the volume that is actually squeezed out of the heart with each heartbeat. So the stroke volume times the heart rate. So what's interesting to note here is now we all have a normal cardiac output of about 4 to 8 liters per minute. And that's because we usually have a heart rate of around 60 to 100. And we usually have a stroke volume of, 60 to 110 or so. Whoops. Heart rate of 60 to 100, not 60 to 1000. Okay, and that is what gives you a cardiac output of about 4 to 8 liters a minute. Now, those of you who have worked in the cardiac ICU, you know that most people, particularly at rest, do fine with a cardiac output to around 2.5. And when you get down to if you get down to a cardiac output of less than 2, then you're going to start having issues because you're going to have decreased perfusion of your organs. Okay, so cardiac output is really sort of the most important parameter of the heart as far as the function of circulation through the body. Now, interestingly, I didn't talk about this with the arrhythmias, but it's interesting to think about how arrhythmias can affect cardiac output. If you have a patient with severe bradycardia, you're going to decrease this heart rate significantly. It's interesting because I worked for a period of time in a cardiology floor, and there were a lot of patients that were getting pacemakers, and I kind of noticed a pattern that people could tolerate being very bradycardic. They could tolerate being bradycardic to around 30 beats per minute. And what's interesting is, if you think about a normal cardiac output of around 4 and a normal heart rate of around 60, you really don't have start having problems with perfusion until you get down to about half. So it kind of makes sense that you can tolerate about half normal before you start having hypoperfusion. What happens when people started getting below 30 beats per minute? They started syncopizing. And if they hang out with a low heart rate, even if they don't have mental status changes, if it's in the low 30s, then you may start to think about perfusion to other organs, so you're going to have to watch out for other symptoms. So this is what heart rate can significantly drop cardiac output with bradycardia. Now, with tachycardia, you also can drop cardiac output significantly because the ventricles don't have time to fill. So if you have a heart rate of 220 Actually, if you're an older person and you have a heart rate of 180 and you've got stiff ventricles, your ventricles might not be able to fill very much. So they're going to have a decreased stroke volume. So they may only be, instead of expelling 80 mLs per minute, maybe they're only able to fill up a little bit, so they're only expiring 20 mLs per minute. So even if even with an increased heart rate, if you have a heart rate of 180, if you've decreased your stroke volume by 75%, you're going to still drop this cardiac output enough to have hypoperfused organs. Okay, so that is how tachycardia and bradycardia can both lead to the same outcome, which is decreased cardiac output, and it's decreased cardiac output that causes the problem. So that brings me to the end of our discussion about the cardiac cycle. Please take a moment to provide feedback by giving a thumbs up or a thumbs down and or leaving a comment. And also, if you'd like to see more videos, then please click on the link below to subscribe to my channel. Thank you very much.